Hi, everyone. This is Sean Sen. So, in the next part of understanding echocardiography for neonatologists, we'll be reviewing left and right ventricular functional assessment. The learning objectives, again, when ordering an echocardiogram, is really to help understand the functional assessment of left ventricular systolic function, both the qualitative and quantitative assessments, as well as the right ventricular systolic function, knowing the qualitative and quantitative assessments as well as we'll be reviewing the markers of pulmonary hypertension. For the scope of this talk, we will not be covering diastolic ventricular dysfunction, as well as some of the other advanced imaging and functional measurements, such as contractility indexes, tissue Doppler, strain and speckle tracking, echocardiography, as well as 3D echocardiography. So why is ventricular functional assessment so important? Well, we know that it's crucial in the evaluation of hemodynamics, particularly in sick neonates. We know that areas like measuring cardiac output through invasive measures, as well as direct CVP measurements, are not always reliable, as well as vital signs at the bedside, such as heart rate and blood pressure, can be quite misleading. So functional echocardiography really can help provide a dynamic assessment with changes to therapeutic interventions, such as starting and discontinuing inotropes, fluid resuscitation, and treating arrhythmias. So before we begin going over ventricular functional assessment, I do want to point out why hemodynamic assessments can be so helpful, particularly using echocardiography. So we know that the determinants of cardiac output rely on myocardial contractility as well as loading conditions of the heart, such as preload and afterload. And this directly is related and can be seen with myocardial fiber shortening, as well as in the big screen can affect ventricular size. And both of these can affect the overall stroke volume. And when we look at the product of stroke volume and heart rate, that really gives us cardiac output. And again, when we look at the relationship between changes in blood pressure with peripheral vascular resistance, we can see that the cardiac output multiplied by your vascular resistance is related to your blood pressure. And of course, changes in blood pressure ultimately affect your loading conditions. With functional echocardiography, the area that really does help provide direct input is that understanding that myocardial fiber shortening, and as well as giving assessments with ventricular size. And again, more importantly, monitoring these dynamically can provide helpful information adjunct to clinical care. So let's go over left ventricular assessment. So the qualitative assessment is really visualization of the chambers, looking at the ventricular sizes and as well as the movement. It's sort of subjective in the sense where trained echocardiologists can have an idea as well as sort of eyeball a subjective assessment in terms of how the function is. When we look at quantitative assessments, we can see the changes in LV dimensions as well as we look at volume in a three-dimensional way. And the predominant two methods that we would describe objectively would be the shortening fraction and the ejection fraction, as well as other modalities such as estimating cardiac output. And we'll review something called the velocity time integral. Again, the advanced measurements, there are several other ways to assess LV function, including systolic indexes of contractility, looking at something called DPDT, as well as the myocardial performance index, and other advanced imaging tools like tissue Doppler, strain, and 3D echo, which we will not be covering. So from a visual analysis, looking at it qualitatively, we look at the overall ventricular size and thickness. During systole, we look at the myocardial thickening as well as the ventricular chamber reduction. And from a subjective standpoint, we would describe what the type of function would be, whether it's on a scale from normal to mild, mild, moderate, moderate to severe, and then severely depressed function. Now, the best way to, this isn't clear cut, but many echocardiographers will correlate ejection fraction and shortening fraction based on these classifications below, as a rough ballpark to overall provide that qualitative LV. So how, in what views do we look at to get an idea of how the LV as well as both ventricles look like? Well, there are several views, and these are the predominant ones that you would be able to take a look at, and we'll go through each one more in detail. So the parasternal long axis, if you remember, this is close to the sternal view with the probe facing to your 11 o'clock. And again, what you're looking for is ventricular function. It can also provide information in valve assessment, the ventricular septum, as well as a relationship to the RV and LV size. In this case, we move to the parasternal short axis. And here you can see, again, another area where you're able to look at the left ventricle and right ventricle in terms of its size. In the typical fashion, you can see that the LV is nice and round, with the RV that's more anterior and sort of creates a crescent shape over the LV. In areas where RV, you see RV hypertrophy, or if you see significant RV afterload in the setting of pulmonary hypertension, for example, you can see the RV to thicken and dilate. And so in this case, you start to see the RV much larger, and as well as that septal position, which we'll talk later in terms of it bowing into the LV. With regards to the quantitative left ventricular assessment, echo is really helpful in estimating the volume of blood ejected during each systole. And so really, ideally, what echo is estimating is an ideal component of stroke volume. There are several limitations and assumptions that are made in this situation, and it's helpful to know that. And so one of the big assumptions is that we assume that the LV is a shape of a cylinder. And because of that, the LV objectively is easier to quantify. Of course, these estimations are dependent on loading conditions, and it's important to know that that these are dependent on afterload and preload, as well as it's dependent on heart rate. In terms of looking at correlation with ejection fraction by the Simpson technique to cardiac angiography, there have been reports and studies to show that there is good correlation. So what is the shortening fraction? So this is a method of looking at the percent change in ventricular dimensions. And it's obtained using a motion mode, or M mode, either through the parasternal long axis or the short axis, which is generally preferred. And what you're measuring is the left ventricular end diastolic and the end systolic dimensions across that M mode. And so if you take a look over here in this mode, here you see in parasternal short axis, where my mouse is pointed, you have that beam that runs through perpendicular to that short axis. And what you see in M mode is the cardiac cycle over a course of time. And you can see here on your EKG where your end diastole is and where your end systole is. And looking at this point and this point, measuring these dimensions, you can calculate the shortening fraction. And so here you can see an example of what a normal LV function would look like with a shortening fraction of 34%, as well as in the setting of a large dilated cardiomyopathy with severely depressed function. And here you can see a shortening fraction of 8%. Again, typical normal values for shortening fraction can range anywhere from 28 to 40%. So another modality to look at, to quantify LV function, is to look at the ejection fraction. And this is a percent change in ventricular volume. And again, using the assumption that the left ventricle is cylindrical, there are several ways to potentially measure that ventricular volume. So you can use 2D imaging from an apical four-chamber in a method called Simpson biplane, which we'll go over, as well as 2D imaging to measure a method known as 5-6 area length method. And then lastly, you could also use M mode in that peristernal short axis using the Tycholz method. Again, typical EF percentages are 55 to 75. And again, the calculation here is below. Here in the Simpson biplane, what you're doing is essentially you're creating discs as you measure the entire cylindrical volume of that left ventricle. And using a biplane, you're measuring two diameters. So you're measuring one in the long axis as well as one in the short axis. And you can do that in the apical four-chamber. And then if you rotate 90 degrees, you can do an apical two-chamber to get that second diameter. So here is an example of actually calculating out the Simpson biplane. And what you're doing again is you're measuring out in end diastole and then also in end systole, measuring the outline of that left ventricle and then creating the summation of those discs. The other way to measure ejection fraction is using the 5-6 area length method. And this is based on the assumption that the LV is a perfect bullet shape. When you look at the volume calculation for a bullet, the equation is 5-6 times the area times the length. And here, the LV length can be measured from the apical four-chamber or subcostal images. And here you can see that that's done on the four-chamber. And then on the right side, the left basal areas, the circumferential areas are measured from the subcostal or peristernal short axis views. So there are several limitations. And again, as we mentioned, that these are dependent on loading conditions, particularly preload and afterload. Again, in situations where you have an unloaded heart, such as on ECMO support, measuring your EF may not be reliable. As well as if you start to have ventricular shapes that are abnormal. For example, in dilated cardiomyopathy, where you may have more of a globular shape, your EF may not be as precise. It's also important to know that in settings where you have ventricular interdependence, where you have, for example, in pulmonary hypertension or RV dilation, you have septal bowing into that left ventricle, which could reduce your volume and ability for calculating an appropriate LV volume that's properly ejected, as well as in situations where you may have ischemia or after, for example, post-cardiac surgery or a VSD repair, where you have intraventricular septal dyskinesia, which also can not give you a precise ejection fraction. And in those situations where you want to have more precise ways, it's helpful to use those advanced imaging methods such as 3D echocardiography as well as speckle tracking echocardiography. Lastly, again, as we're calculating predominantly velocities, it is interesting to see how echocardiography can estimate cardiac output. And here, using the understanding that cardiac output is a measurement of stroke volume times heart rate, we can estimate stroke volume using echocardiography by this method. And so here, what we're doing is, one, if we know this volume, we would measure the cross-sectional area of the aortic valve, and we can do that on a peristernal long axis. And then over here, in order to get the volume, we use something called the velocity time integral. And what that is if we can measure an aortic Doppler from the 5-chamber apical view, And we measure here the area under the summation of all the velocities during systole, and we calculate that area under that velocity time curve. We call that the velocity time integral, or the VTI. And so the VTI here times your cross-sectional area is essentially an estimate of that stroke volume. And if you multiply that by heart rate, you have an estimation for cardiac output. Again, there are limitations. Estimating this is technically challenging and does require training. But when research, from a research standpoint, there is good correlation with angiography in comparing invasive techniques such as the Fick method or during thermodilution in cardiac caths when calculating through that LV outflow tract. The other thing is that, again, assuming that your aortic diameter does not change, you can also track your VTI separately to monitor in hemodynamic changes. And so this paper had related from a point-of-care ultrasound being able to change inotropes and be able to follow through cardiac dysfunction. VTI separately was helpful in being able to track that. So let's review the right ventricular assessment. So again, we'll be looking at the qualitative assessment of looking predominantly at the RV size, hypertrophy, as well as overall movement. And then the quantitative assessments, looking at two measurements, one known as the fractional area change, or FAC, and then the other one, the tricuspid annular plane systolic excursion, also known as TAPSE. So the right ventricular anatomy, assessing that size and function is more challenging than the left ventricle, and there's several reasons. And really, the main reason is the complex geometry of that right ventricle. As you can see, that left ventricle is very typical. We were talking about how it presumes a bullet shape, how it's cylindrical, but you can see here in this gross anatomy picture that there are several components to the right ventricle, including an inlet portion, an outlet portion, and a trabecular or apical portion. As well as when you see how the right ventricle is almost in a crescent shape, hugs that left ventricle. I've said, I think before, if you take your left hand and make a fist, and then take your right hand and sort of cup that fist, you can kind of get an idea of how the right ventricle is in relationship to that LV. And when we look at that right ventricle, we oftentimes call that tripartite. And so, again, limited by these objective measurements, in the past we've predominantly relied more on quote-unquote eyeballing or giving a more subjective assessment qualitatively about the right ventricular function. So similarly, the same views to look at the right ventricle predominantly are in the parasternal long axis, the short axis, as well as your apical and subcostal views. The apical four-chamber is probably one of the best views to take a look to see and get an idea of the relationship between the ventricles, as well as look at the LV-RV size. Here on the right-hand side, you can see the typical discrepancies between the dilated right ventricle as well as a significantly globular dilated left ventricle at the bottom. Again, when we look at the parasternal long axis here again, in terms of looking at the RV to LV ratio, one study showed that the comparison of 80 normal patients with 84 children with pulmonary hypertension, showing that the RV to LV ratio greater than 1 was consistent with adverse clinical events. And those events included disease progression requiring initiation of IV prostacyclin, if it included clinically indicated creation for an atrial septostomy, death, or transplant. If we look at the parasternal short axis, it's helpful to really look at the interventricular septum. And in this case, as you increase RV afterload, again, we talked about the crescentic shape of the RV, as well as that rounded septum, interventricular septum. And as you start having a dilated RV, that septum really starts to flatten. And in situations where you have severe RV afterload, you end up seeing a flattened or almost a D-shaped septum. So here you can see, again, the position of that ventricular septum during end systole in parasternal short axis correlates with right ventricular systolic pressure. And in this case, a normal rounded septum, you can assume that the right ventricular systolic pressure is less than half systemic. A flattened septum, you can assume that the right ventricular systolic pressure is greater than half systemic. And if it's bowing, the right ventricular systolic pressure would be suprasystemic. So again, qualitative assessment of the RV can be challenging, and it's helpful to describe and identify limitations. So in echo reports, if they've mentioned septal dyskinesia, septal flattening, these are descriptions to try to help understand those limitations. When we look at the quantitative assessment, the two predominant measurements that are described in echo reports would be the FAC, the fractional area change, and TAPSE. So what is the fractional area change? It's the percent change in the RV chamber size from end diastole to the end systole. It is dependent on loading conditions, as similar to the LV quantitative assessments. And then there have been studies that have shown that it correlates well with RV ejection fraction from MRI studies, particularly this study that showed it in patients with PH. There was also a study looking at preterm neonates reporting significantly lower FAC in infants with moderate to severe BPD compared to non-BPD cohorts. In this paper, it suggested that the author suggested that FAC may be used as a longitudinal assessment in patients who would be at risk for increased RV afterload and with subtle changes in RV function. So TAPSE is an interesting thought, especially when it comes to a quantifiable measurement of systolic function. And the concept is that when you look at RV contraction in comparison to how the LV contracts, the predominant motion is longitudinal. And so that longitudinal motion helps in terms of being able to describe what that change is from a planar view. And so the thought is, if you take a look at on the left hand, this video right here, there are two things to kind of see. As that RV contracts, you can notice that the apex doesn't move as much. And you can see that the predominant motion, especially when you look at the difference between diastole and systole, is where that tricuspid valve movement is. And so the thought behind this is that if you placed an M mode at the lateral free wall annulus of the tricuspid valve and draw a parallel line as much as possible from that tricuspid valve excursion to the apex, you can run that in an M mode, and you can see a difference in that tricuspid valve annulus. And if you measure the difference between diastole here and systole here, you can measure a distance between the two, and that would be that displacement measured in centimeters. And in terms of normalizing and being able to provide z-score values, this was the largest prospective study looking at TAPSE. They looked at 640 healthy patients from anywhere from age day 1 to 18 years. They did show that TAPSE increased with age with a mean of 0.91 centimeters in neonates to 2.47 in 18-year-olds. There was a positive correlation with age body surface area, and there was no significant differences between male and female. So we've talked a lot about the qualitative as well as quantitative measurements of right ventricular function, but how does echocardiography and pulmonary hypertension play? So echocardiography can be used, and it is used as a non-invasive assessment for pulmonary hypertension. When we looked at how reliable that is, we found that, again, echo correctly diagnosed pH in almost 80% of patients where pulmonary pressures could be estimated. However, you can see in terms of actually being able to measure the severity and the accuracy of pulmonary hypertension, the correlation here is pretty poor. And so here, this was a study done in 2008 where they looked at, again, your systolic pulmonary artery pressures measured by echocardiogram in comparison with cardiac cath. And you can see how poorly it correlated. So what measurements are useful to measure pH? The expert consensus, this was an expert consensus paper from the European Pulmonary Vascular Disease Network, and they identified an extensive list of useful markers for the overall evaluation for pulmonary hypertension. And you can see that there are many of these markers that are used for RV function can be used to describe the degree or presence of pulmonary hypertension. We've talked about RV-FAC, the RV-LV ratio, TAPSE, pulmonary artery acceleration time, as well as many others. And also what we haven't discussed yet, but also going over the tricuspid regurgitation peak velocity. So what is your TR gradient or your peak velocity? It's helpful to estimate predominantly the right ventricular systolic pressure. And so on an echo report, if there is a good TR, and when we say good TR, the ability for your tricuspid regurgitation to show a nice envelope so that there isn't any areas where you're not able to capture the TR, it's helpful that we would be able to measure where that peak tricuspid regurgitation velocity would be. And if we're able to calculate what that velocity is, you can use a modified Bernoulli equation with certain assumptions that your TRV max squared times 4 would give you an estimate of that RVSP. And this is in addition to your right atrial pressure. This is again described relative oftentimes to the systemic systolic pressure, whether it's described as half systemic or suprasystemic or near systemic. In the presence where tricuspid valve regurgitation isn't there, other areas such as PR, pulmonary regurgitation, as well as the PDA Doppler can be used to give estimates of your pulmonary artery pressure. So again, there are limitations. Not all infants with PH will have TR or PR, let alone this can be reported, as mentioned, when they say an incomplete envelope. Here's a picture of that in terms of it's hard to see where the full envelope is, and so you aren't sure where that peak velocity is. It could be anywhere here, but unfortunately, we're not able to capture that TR appropriately to know exactly where that peak is. And so whenever you see something like this, it's hard for echocardiographers to describe exactly what the TR would be. As well as the accuracy, again, here we're presuming what the RA pressure is, as that it needs to be added on to the right ventricular systolic pressure. And then again, knowing that RV hypertension may not equal pulmonary hypertension, especially in the setting of if you're assuming that there is no RVOT obstruction or pulmonary valve stenosis that would affect your pulmonary pressures. And then again, as mentioned, that there overall is a poor correlation from echocardiographic findings with pH severity. So we'll finish up with screening guidelines for BPD. In 2015, the Pediatric Pulmonary Hypertension Network came up with these, and I would suggest everyone to be familiar with these. But in essence, they described that in severe hypoxic respiratory failure after birth, attributed to either PPHN, a echo screening would be appropriate. In neonates that are requiring ventilator support at day of life 7, echo evidence of PH suggests that there's a high risk for BPD, as well as if there's sustained need for significant respiratory support at any age, especially with recurrent hypoxia, changes to physical exam or clinical status, and high FiO2 requirement. And then at the timing of BPD, typically at 36 weeks post-menstrual age, screening echo is recommended to rule out pulmonary hypertension. And lastly, when echocardiography is indicated for pulmonary is helpful to show pulmonary hypertension, when would you go and get a cath? And so some guidelines or some thoughts: severe PH, again, by echo or clinical deterioration not attributable to parenchymal disease, as well as significant PH despite optimal respiratory management, confounding variables such as known intracardiac shunts that may limit the PH assessment using echocardiography. If there's concern for pulmonary vein stenosis, we know that echocardiography, even by Doppler, is a poor assessment in terms of actually identifying pulmonary vein stenosis. And then, again, consideration for any long-term vasodilatory therapy, having a cardiac cath to have baseline hemodynamics would be helpful. Again, these would also be in discussion with your cardiology colleagues to figure out when to do that. Thank you very much.